Hello and welcome to our second virtual Lunch and Learn series. Today we're going to be talking about rural oral health. You can head to the next slide. So before we get started, I want to talk to you a little bit about American Institute of Dental Public Health, or AIDPH. My name is Liz Flannery. I'm the Director of Education and Leadership here at AIDPH and thrilled to be here with you today. Our organization is a nonprofit. We're committed to transforming dental public health practices through science, education, and advocacy with programs such as what we're doing here today. This work serves as a catalyst for change. AIDPH advocates for a justice-oriented oral health system that prioritizes equity and inclusion. You can go to the next slide. Our mission is empowering our community to advance oral health through science, education, and advocacy. Our community being folks like you, predoctoral students, dental public health professionals, as well as the broader community, and we're working towards a justice-oriented oral health system. And as participating in programs like today, you are part of this mission and vision, so thank you for being here. You can go to the next slide. We have 4 communities of focus at AIDPH. These are communities that have been historically excluded, marginalized, and underserved, particularly when it comes to oral health. And these communities include LGBTQIA+ people, veterans, people with disabilities, and people living in rural communities. You can go to the next slide. And I'm going to pass it off to our Executive Director, Annalise Cothran, to talk a little bit more about our model and rural oral health.
Thanks so much, Liz. Hi, everyone. Thank you for joining us today. My name is Annalise Cothran. I use she, her pronouns. And as Liz mentioned, I'm the Executive Director of the American Institute of Dental Public Health. And as Liz also shared, through our 4 core communities of focus, we take a highly invested approach to community engagement. Not only do we work within those 4 core communities, of which today we'll be talking about rural oral health, but we also work at the intersection of those communities. So as we go through our presentation today, you'll hear a lot about rural veterans. You'll also hear some about people with disabilities living in rural areas, because there's a lot of crossover and overlap in the work that we do here at AIDPH. And the way that we do this work is through a community engaged approach. That means that AIDPH as an organization brings knowledge, expertise, capacity, and support, where our community partners bring lived experience, representation, and most importantly, they represent the activities where direct benefit will occur. And because of this investment and community engagement, AIDPH has developed the first oral health community advisory board that is focused on the lived experiences of our core communities. So that means that folks from rural areas are included on our advisory board, veterans, LGBTQIA+ people, people with disabilities, and also the intersection of all of those areas. And because of our investment and community engagement, we actually create opportunities for that to permeate through all of our programming. Like Liz mentioned in the beginning, AIDPH focuses on research, education, and advocacy. And because of our focus on education, through opportunities like this, we really have a lot of varying investments, strategies, and mechanisms of learning about our core communities of focus, the broader oral health workforce, oral health equity and justice, and all kinds of areas in between. And so what you're experiencing today is a webinar and a workshop, and just one of those one-off opportunities to learn more about dental public health in general. But we have many strategies and outlets for investing in a dental public health educational experience that's often complementary to formal education. One of those opportunities is our Rural Echo series. So if you're listening in today and rural oral health is something that interests you and you want to learn about more, we actually have an entire dedicated series to rural oral health that focuses on the oral health of rural people through case-based learning. And it also really focuses on a very diverse, broad range of personal and lived experiences as it relates to rural oral health and those overlapping and intersecting inequities. We also have transformed our ECHO program. Once we finish a series, we transform them into certificate programs. So Liz is going to share a little bit more about these certificate programs at the end of today's discussion. But we wanted you to know from the very beginning that if this is a topic that interests you, we have opportunities for you to invest your time and energy into learning more, and also getting some recognition that this is a topic that you have some specialized knowledge in. Okay, so let's talk about rural living in a snapshot. I'm going to be sharing some data with you that comes from our partners at the National Rural Health Association. And I've also gathered data from Rural Health Info Hub. I have given you those resources at the end of this presentation, but I wanted you to know from the very beginning that we've pulled from available data, and we also have our partners at the National Rural Health Association who've allowed us to use some of their data today to present to you. So broadly, when we talk about living in a rural area, what does that mean, and what do those lived experiences look like? Well, first of all, capturing rurality. Number one, there is varying definitions and degrees of definitions, and also degrees of rurality. You can be living in a non-metropolitan area with varying, widely varying ways of measuring and capturing rurality, all the way from being designated as rural, all the way into frontier areas, which means it's a sparsely populated, highly kind of land and farming and agriculture focus in those frontier areas. Very few people live in those areas, but you can also be considered rural in a variety and in a spectrum of environments. So let's go through what that means whenever you live in a rural area. What do you experience, and what does that look like for you as a rural person? So you may not know that the majority of the US counties are rural. The majority of the US population does not live in a rural area, but landmass wise, most of the US landmass is in a rural area. So that means that rural people are everywhere. And it's an incredibly unique population. Again, I like to talk about rurality in the context of our 4 core communities of focus, because there are queer people living in rural areas, there are veterans, there are disabled people, there are a wide range of diversity that is located in rural areas. And in fact, what the data tell us is that rural communities are actually getting more and more diverse from a few different perspectives. The data here presented are actually data on racial diversity. And what we found is that by and large, rural communities are largely white, over 70% white. But when we look at the age distribution, we actually see that more and more rural people who are non-white are living in rural areas. And in particular, they are young. Younger people are, and more racially diverse people are now populating those rural areas. And so we expect the trajectory of rural communities to look very different in the next decade and 2 decades because of this shift into rural areas, and also a recognition that rural areas are becoming more diverse. One of our core communities of focus, one of our core collaborative areas has really been an investment in tribal communities and Native people who live in those communities. We recognize that what you see as the US landmass has actually always been, has always belonged to Native people, and that tribal areas are located everywhere. And unfortunately, tribal lands have also dramatically decreased over the past many, many years. And so while tribal communities and tribal people live everywhere, they are also highly concentrated in rural areas as the first peoples of the United States and the Americas. So tribal people are make up about 5% of all rural people, and tribal lands are also disproportionately located in rural areas. And in fact, when you look at the breakdown of where tribal people are located, there's high concentrations in Alaska for the Alaskan Natives. And then we see that, again, landmass-wise, tribal lands cover a lot of rural areas. So when we look at important demographics, stakeholder groups, we need to recognize that Native and tribal people are a really big consideration when we're talking about rural health, and also cultural competency, cultural sensitivity, and cultural affirmation when it comes to delivering healthcare services in these areas. As I mentioned, we were going to be talking about rural veterans because we also understand that veterans are disproportionately located in rural areas. Again, veterans are largely white and male, and we also know that rural areas are largely white. So this makes sense from a demographic perspective, but we've also seen over the past several years, particularly in light of the pandemic, since 2020, we've seen a massive shift, like we haven't seen in decades previous, where people are actually going to rural areas. There has been a shift and an increase in people relocating more into rural areas than they have previously, and that does include veterans. Ultimately, when we're talking about what rurality looks like, borrowing from our friends at the National Rural Health Association, we know that there's more diversity, there's a greater population of veterans, there's a high concentration or population of tribal people. And when we look at the breakdown of rural communities, we know that rural communities are older. And unfortunately, we also understand that rural communities have higher prevalence rates because of the structural inequity that's located in rural areas. We understand that people living there have higher rates of chronic disease conditions, that social emotional factors contribute to high rates of mental health issues. And we also recognize that those high-risk issues turn into chronic disease conditions and also environmental risk factors associated with living in rural areas. And while I'm trying not to paint a picture of bleakness in rural areas, we also have to be very real about the challenges of people living in rural areas and how it affects their health. I like this quote by Alan Morgan from the National Rural Health Association, who shared very recently in our ECHO series that rural America does have many challenges. There are workforce shortages, there's chronic poverty, and a lot of vulnerability in this kind of high-risk population. However, the resilience of rural communities and an asset-based approach really means that there's opportunities to leverage to overcome those particular obstacles, and that the solutions are often really innovative. Rural areas drive innovation, and that's really clear when we're looking at how that asset-based approach has policy change implications that help everybody, rural and non-rural Americans in the end. So now that we've given a little bit of an overview about who lives in a rural area and what they might be experiencing, let's talk a little bit about the health and oral health of rural people. So this is probably a statistic that you've heard somewhere in the public health landscape, which is that America's rural hospital crisis is dire. Rural hospital closures were actually increasing before the pandemic, but as a result of the pandemic and in 2020, rural hospital closures are now really causing a crisis. It's very dire. Not having access to basic care means that people living in rural areas are driving further, they're delaying care altogether, or they are creating situations where care can only be provided through an emergency department. That means that care is costly, it's probably painful, and it's really creating it's perpetuating what we've talked about a couple of slides ago, that rural people are living and sicker and more poverty with inadequate access to care. Again, highlighting those chronic disease conditions. When we look at the prevalence of Medicare patients with 6 or more chronic disease conditions, they are disproportionately located in rural areas. Yes, that is certainly located predominantly in the South, as you see here, and throughout the Rust Belt, but chronic disease conditions are higher prevalence in these areas. We're also looking at chronic disease conditions in particular that exacerbate poor oral health. So people living in rural areas have higher prevalence of obesity. They have higher prevalence of heart disease and diabetes. And we know that this has a bidirectional effect on their oral health outcomes. So when we couple that with the consideration that people living in rural areas also now have less access to medically necessary care, and that their care delivery sites have been constrained since 2020, it's really creating a crisis of being able to manage these disease conditions effectively, both from a quality of life and also from a financial perspective. There are key challenges associated with rural oral health. Some of them we've already talked about, like the lack of available infrastructure and the lack of available workforce, et cetera. However, we know that people living in rural areas when you can access a dental provider, it's far less likely that you'll have insurance to cover that care. And when you walk into a dentist's office or talk to an oral healthcare provider, there's a high chance that there are complicating factors like substance use, and mental health issues that may be affecting your ability to create a more effective oral health solution. And in fact, when we're looking at outcomes, the oral health of rural people, because of these structural issues, the oral health outcomes are usually significantly poorer. And people living in rural areas have more gum disease, they have more decay, and sadly, they have much higher rates, almost double rates of indentulism. And when we couple that with less insurance coverage, fewer dental appointments, and less workforce to be able to deliver that care, it creates a very complicated situation when considering the overall picture of rural oral health. So this is from the Rural Health Info Hub, and we talk about where dentists are located. It is not in rural areas. So there's a designation provided by the Health Resources and Services Administration that's called Health Professional Shortage Area, and you've probably heard of this. A health professional shortage area is an area without enough providers, depending on the specialty, to be able to implement care. And in this particular visualization in front of you, we're looking at non-metro or rural areas and the number of dentists that are available for that population. And so you'll see in these rural areas, all of those light areas are the areas that do not have enough dentists available to meet the needs of that population. So yes, these are low dentist to population ratios, but one thing to consider is that there are other oral health providers located in those areas, like dental assistants and hygienists that are available to support the needs of the oral health workforce. And one consideration is how we can utilize those other oral health providers in the provision of care to rural people. And in fact, when we're looking at dental HIPSAs, 2/3 of rural people are located in a dental health professional shortage area, and 1/3 of rural people do not have any dental insurance coverage. So this is a complicated issue of both utilization and access with the availability of the oral health workforce in rural areas. So when we talk about solutions, we have to understand that the infrastructure located in rural areas is simply not the same as it is in urban areas. We talk a lot about telehealth and teledentistry as an option for supporting geographic barriers to accessing care, but that's only an effective option if broadband is available in those areas and if you can actually afford to pay for internet service. And because rural America disproportionately lacks the infrastructure to support broadband, and because many rural Americans are living in poverty, we really start to wonder what kinds of solutions are available to people living in rural areas, knowing that telehealth needs both of these things to be an effective support of rural oral health. So taken together, this paints a very fragile picture of the rural health safety net. We have vulnerable populations who are sicker, poorer, and older. And we couple that with systemic workforce shortages, of course, in oral health, but also broadly in primary care. We also recognize that the infrastructure for care delivery becomes more and more strained with the closing of rural health access centers and FQHCs in rural areas. Complicating those issues are the lack of providers in those areas and the lack of structure to facilitate technology and innovation like telehealth. So, really taken together, people living in rural areas deserve policy solutions that increase access to care and improve their oral health and well-being. And AIDPH has some suggestions for improving the oral health of people living in rural areas. And frankly, as I mentioned at the very beginning, these solutions also improve the oral health of many people. So investing in the right infrastructure and the right resources ultimately helps all people living in underserved areas, including those in rural areas. So number one is ensuring that our oral health workforce is maximized. As I talked about, yes, we do have a shortage of dentists in rural areas and workforce more broadly, but being able to use all oral health providers to the top of their scope and licensure is critically important, and ensuring that when oral health providers are present and available, that they are also utilized. And in rural and underserved areas, there are lots of workforce solutions like dental therapists, expanded function dental hygienists who can actually work as more effectively as part of the oral health care team. Number two is ensuring that integrated care and models of delivery and payment are considered in rural areas. Like many underserved populations, rural people are dealing with high rates of chronic disease conditions that exacerbate poor oral health. We know that considering your oral health care in relation to these chronic disease conditions and vice versa means that everybody is paying less money, both payers and patients in terms of out-of-pocket costs. We're saving money by an integrated system, but also that these high-risk, high-cost populations, like people living in rural areas, facilitating a value-based framework means that that risk is offset and that we can incentivize people to be healthier. And oftentimes that means that providers are more motivated to be in those areas whenever we're thinking about payment models that benefit patients, providers, and payers. Number three, which I already alluded to, is ensuring that there's enough infrastructure in these rural areas. Our FQHCs are a critical delivery site for both integrated care, value-based care, and also just generally supporting the care of underserved people as the safety net in the US. So expanding the availability of FQHCs, particularly those that support Medicaid and Medicare patients, many of whom are rural, can improve that safety net support for people in these rural areas, including rural access clinics. Expanding broadband and telehealth access is crucial. Telehealth is a really effective tool and can help with triaging and ensuring that rapport is built between patients and providers. But telehealth is only as available as the broadband and infrastructure around it to deliver that tool. So in general, broadband needs to be everywhere, and it also needs to be affordable. Lastly, improving the data collection for oral health indicators is really crucial. Often underserved communities, like people living in rural areas, are not considered in data collection processes. And so that means that we really don't know some of the struggles that rural people are facing because we don't have the data to create informed interventions. And so as we think about creative solutions to collecting data in really small communities, like rural areas, as we invest in those evaluation and surveillance mechanisms, we also inherently will improve the data and the interventions that we can create as a result of better data. So if you want to learn more about rural health, don't worry, we have the resources. As I mentioned at the very beginning, Rural Health Info Hub is the best place to go for more data on rural, but also just health information in general. I use this tool all the time. It's supported by the Health Resources and Services Administration. It has really, really cool visualizations that allow you to drill down to the county level about what, like, rural demographics, poverty, veterans, all kinds of things, what that looks like for your community. There's also tons of toolkits available, case studies that you can use to share out as an educator. So just a great place to get information, and it's very user-friendly and also updated very frequently. The Center on Rural Innovation is also a really fantastic resource. They put out reports at least annually, if not more. Lots of cool data visualizations, but really what they focus on is how to leverage technology in rural areas, how to drive innovation using those asset-based approaches. And there's a really big focus on community engagement and leveraging that in rural areas. I don't know if people realize, especially in the public health arena, that the USDA has a ton of information on health in rural areas. And in fact, they have a really cool visualizer, data visualizer too, on their website. So you can learn about rural America, both the demographics and some of the health indicators associated with rural. And I don't think that that's always kind of an inherent place that people would look, but there's lots of great information on the USDA website. And lastly, AIDPH is a great place to go. If you're looking to understand specifically rural veterans, we have created a lot of resources, several publications, and state profiles that help you look more closely about the oral health and well-being of rural veterans. We know that, again, veterans are disproportionately concentrated in rural areas, and so it remains a very important demographic to both support from a care delivery perspective and understand from an informed solutions perspective. So if you head to vetdentaldata.org, you'll be able to learn information about veterans broadly and then rural veterans specifically. Our partners of the National Rural Health Association do have a national rural health initiative, rural oral health initiative. So there's lots of resources there, but if you're also looking to be more involved in rural health nationally, there's a place for you to do that. within the National Rural Health Association. They also create pipelines for providers to work in rural areas. So if rural oral health really interests you as a potential career path, then NRHA is the place for you to go to learn more information. And they're also just really wonderful partners and advocates for rural health broadly and rural oral health specifically. And with that, I'll turn it over to my colleague, Liz.
Thank you, Annalise, for that wonderful and thorough presentation on rural oral health. I'm going to talk a little bit more in depth of some of the pieces we talked about at the top of the call and the programs we have that you can do to stay in touch with AIDPH and participate in some of our professional development and education programming. So one of the pieces that Annalise spoke about at the beginning of our call was our certificate programs, particular to rural oral health. So we have been doing, we're in our third year of our Rural Oral Health Hella Echo program, and we are having a live series of those happening this year, but we also have our recorded sessions from 2022 and 2023. We have a separate certificate program attached to each of those series that can be accessed in a self-paced manner. They're free of charge, and those are available on our website. So if rural oral health is something you're interested, I strongly encourage you to look at that information and pursue one of those certificate paths. If you have any questions about that, you can reach out to us. We have our email and website at the end of this presentation. And we're happy to talk through kind of the steps to take to get those certificate programs. We also encourage you to join us at our live seminars that are happening for ECHO. That can also be found on our website this year. And you can pursue in real time a certificate program with that series as well. We can go to the next slide. And Annalise spoke about the Academy and how we have a range of programming available under our education umbrella here at AIDPH. We currently have our fellowship programs open, two of which include the Federal Service Immersion Program and our Dental Public Health Leadership Academy. The Federal Service Immersion Program is an incredibly unique program where we gather together with a cohort of about 20 folks in person in DC for a week, where we visit most of the federal health agencies, and you really again, it's just an incredibly unique opportunity to get one-on-one time seminars directly with the folks working at these federal agencies to understand the intersection of policy and budgeting and dental public health programming, to understand grant and funding opportunities, and most importantly, federal career pathways if that's something that you're interested in. This year is particularly exciting. We have an optional advocacy day that's happening at the end of the program. So we'll include those federal health agencies as well as time working with our legislators and sharing education around oral health needs and how we can increase access to oral health for our country. That application is currently open and it's closing at the end of the month. So if you're interested, we encourage you to visit our website, look at that information, and again, always please feel free to reach out and email us with any questions. We can go to the next slide. Annalise spoke a little bit about our academy at the top of this call as well. This is really a graphic image of the different programming that we offer. And as an organization that is working with our dental public health workforce, we really strive to offer a diverse range of programming that fits the different levels of time commitment and in-depth knowledge that people have time for and are interested in. So again, we have everything that ranges from maybe a standalone webinar, a short training series, moving on to learning collaboratives where folks can come together in a very collaborative way and learn about a certain topic, but it's less formal in that there's no CEUs attached there. We have our certificate programs, again, like the Rural Oral Health, where it's a dedicated curriculum with a set number of seminars to attend, with competency evaluations attached to it, with a certificate at the end of the program. And again, those can be followed in a self-paced manner. We have our fellowship programs, which are a bit more intensive. Those are really in depth. Our FSI is a week long, but it's an intensive program. And our Dental Public Health Leadership Academy, that's a 12-month long cohort-based program. We also have a summer fellowship that happens every year, and a summer research internship that happens. And we have our colloquium, which is our annual in-person conference that happens every year that's really bringing our dental public health leaders on innovative topics. And it's a time to network, but also really understand different research pathways and what folks are doing and what data gaps are out there for people to pursue in their careers. You can go to the next slide. So again, we have our information here, and we hope that you'll visit our website. And if you have any questions, please get in touch with our email here or our phone and let us know what questions you have. Again, thank you so much for taking time to join us, and we'll talk soon. Thank you.